views expressed in this podcast do not reflect those of our training institutions or the APA. The information discussed is intended for educational purposes only and should not be used for diagnosis or treatment. Enjoy! Hello everyone, and thank you for joining us. My name is Bharat Sampathi. I'm an editorial board member of the AJP Residence Journal. Today we have with us Dr. Alyson Gorun to discuss psychoanalysis and psychodynamic psychiatry, the history and future of these forms of therapy and psychiatry, comparisons with other forms of therapy, training opportunities, and more. Dr. Gorun received her undergraduate and medical degrees from New York University. She completed her residency training in psychiatry as chief resident at the New York Presbyterian Hospital, Weill Cornell Medical Center, and a reproductive psychiatry fellowship at the New York Presbyterian Hospital and Columbia University Medical Center. She has published and presented nationally in a number of areas including psychodynamic psychotherapy, women's mental health, trauma, and resident education. She is currently a candidate in adult psychoanalysis at the Columbia Center for Psychoanalytic Research and Training and the Aaron Stern MD PhD Research Fellow in Psychodynamic Psychiatry at the New York Presbyterian Weill Cornell Medical Center. Hi, Dr. Gorun. Thank you for taking the time to speak to us today. How are you, and how are things on the East Coast in terms of the COVID-19 pandemic?
Hi, thanks so much for having me. I'm so grateful that things are much quieter now in terms of COVID in New York.
Yeah, it seems like New York has fared relatively well during the resurge. For our listeners, it's the second week of July 2020. California this past Tuesday had a record 6,500 new cases, and our governor actually reclosed all indoor activities for most of the counties in our state. So I understand that your institution switched over to telehealth as well. Have you noticed any changes in your experience or your ability to function as a therapist virtually?
Yeah, everything that can be done remotely is being done remotely for the time being. But in some ways, it's actually been really great. The no-show rate has decreased a lot. And, being able to see my patients in their home environments has actually been extremely useful sometimes. It's definitely a different experience as a therapist, but I think it can also provide a lot of new data that ultimately I think can be helpful.
That's interesting. I never thought about how you could benefit from seeing a patient's home environment. Do you have any examples you don't mind sharing?
Yeah. Without going into specifics, observing how someone functions in their home and manages or has difficulty managing, their space, privacy, interruptions from work, family, or others, just to name a few, can tell me a lot about how they manage those things outside of the telepsychiatry room.
Yeah, that's interesting. I never thought about that aspect of telehealth.
Mm-hmm.
So moving on to the main topic of this podcast, the reason I wanted to speak with you regarding psychoanalytic and psychodynamic psychiatry is because me personally, I'm fascinated by the power of exploring the unconscious mind, specifically learning its intricacies and how various experiences in your life can shape the unconscious and ultimately influence who you are in present day. In my opinion, a means to catharsis and the ability to identify pivotal moments in your life to create a greater sense of awareness is priceless. And my first question is, so for residents like myself, mainly PGY 1s and 2s, without having had all of their didactics in psychotherapy, may have trouble understanding the difference between psychoanalysis, psychoanalytic therapy, and psychodynamic therapy. Can you tell us about some of the differences between these modalities?
Yeah, absolutely. So first, just some definitions with all the different terms. So psychoanalysis is different from psychoanalytic psychotherapy. And then psychoanalytic psychotherapy is the same thing as psychodynamic psychotherapy. So other terms that are sometimes also used interchangeably include insight-oriented psychotherapy and expressive psychotherapy. So I know those are a lot of words for the exact same thing. But really, any therapy that uses a psychodynamic frame of reference is a psychodynamic psychotherapy. So what that includes is a psychoanalytic model of the mind and using techniques such as interpretation of transference, defenses, and resistances of some others. And the way that psychoanalysis and psychoanalytic psychotherapy are different include kind of broadly which techniques are emphasized, differences in the frame, and what kind of patient difficulties it's addressing. So psychoanalysis may focus more on the transference as the therapeutic mode of action and a little less on day-to-day events of the patient's life, which may be more of a focus in a psychodynamic psychotherapy. The frame in psychoanalysis includes the patient lying down and facing away from the therapist, in addition to more frequent sessions per week, generally 3 to 4. A psychodynamic psychotherapy has the patient sitting up and facing the therapist. It's usually only 1 to 2 sessions per week. And then if you look at the indications for psychoanalysis, it usually includes kind of entrenched, long-standing and maladaptive patterns that require more intensive work to understand. And then psychodynamic psychotherapy is better suited for a patient with a more specific difficulty that a focused treatment can address, or for a patient who is, unable or unmotivated to do a more frequent and in-depth treatment. Additionally, patients who are at risk of becoming destabilized by an intensive psychotherapy, or when they do become unstable, engage in unsafe or risky behaviors, those people may also be better suited for a psychodynamic psychotherapy or a different kind of treatment altogether.
Interesting. Okay.
To add to all of this, supportive psychotherapy is sometimes put on the spectrum of psychodynamic psychotherapy and psychoanalysis, in which non-uncovering techniques are used to address maladaptive defenses, and transference is used to help the patient, but without actually interpreting it. There are also some psychoanalytic psychotherapies that have become manualized, such as transference-focused psychotherapy, panic-focused psychodynamic psychotherapy, mentalization-based therapy, and supportive expressive psychotherapy. And then lastly, to kind of add to this bucket of terms, the term psychoanalytically informed or psychodynamically informed therapy or intervention is also used. So this describes using a technique or theory based on a psychodynamic or psychoanalytic understanding of the patient without the kind of typical frame. So a great example of this is when you help a patient understand their ambivalence towards taking a medication, or using your understanding of a patient's distress to de-escalate them in the psychiatric emergency room. Both are actually examples of a psychodynamically informed intervention.
I didn't realize there were so many branches off of psychodynamic psychotherapy, and I'm curious as to how psychodynamic concepts via the psychodynamically informed therapy you mentioned can be applied to the emergency room, where you're meeting someone for the first time in a fast-paced environment. I imagine it can be a little difficult to identify maladaptive behaviors, transference, things of that nature in such a short period of time.
Yeah, I'm so glad that you made that comment. That's a really common misperception about using psychodynamics, that it's only applicable to outpatients, in a long-term relationship. So whether you're in the emergency room, inpatient hospital setting, or in the consult service, patients tend to recreate their internal object relations in whatever environment they're currently in. And what I mean by that is the way that they typically relate to others. It's also going to occur with you, and it's also going to occur with the treatment staff. So this, again, can tell you a lot about who this patient is, what they might be struggling with, but also, effective ways to interact with them interpersonally to de-escalate and move treatment planning forward.
Okay.
So one great example of this, and really common, is the recognition and use of negative countertransference. So this is something we as clinicians sometimes feel even before we talk to the patient. It can come just from watching someone enter the ER, escorted by police, angrily declaring that they want to leave. Your negative countertransference can come from, a whole host of projected feelings that the patient is experiencing, such as feelings of being helpless, hopeless to be able to offer anything to this patient, maybe feelings of anger towards them. But knowing that your experience may actually reflect the patient's experience can help you then instill hope, motivate change, address their anger at, maybe they're feeling controlled or misunderstood in that setting. So that way you can also use your awareness of your negative countertransference to prevent you from a clinician from potentially avoiding this patient or enacting your feelings in some way that's not beneficial to them. So a lot of the techniques we use to de-escalate are actually rooted in psychoanalytic theories. So things like empathic mirroring and providing a holding environment. Those are two principles that I think every clinician uses in the emergency department and otherwise to provide relief to patients in distress.
Mm-hmm.
I think another commonly used idea stemming from psychoanalytic theory is the phenomenon of splitting and how this affects treatment. But there's a lot more written on this in the literature on this subject.
That makes a lot of sense. And I think as a resident, I feel I experience exactly what you're explaining, like the countertransference and using it to ultimately help patients in inpatient settings. But without consciously knowing it, it's actually quite helpful that you're able to put it into words, discussing the countertransference and identifying how it can help influence your interactions with patients to ultimately provide better treatment. For example, in terms of their communication style with staff or yourself. So I think that's really valuable to hear that from your perspective. What drew you to further training in these forms of therapy?
Yeah, I mean, definitely my experience in medical school and residency with patients. And then, my interactions with my mentors were the primary influence guiding my decision to do additional training in psychoanalysis. I often felt the patient who had a psychodynamically informed psychiatrist or therapist really understood the patients in a deep way that other psychiatrists didn't. And those who didn't at least kind of consider the underlying dynamics seemed to be missing this huge elephant in the room. Once you've kind of seen how psychodynamic principles can operate, both within patients, but also amongst groups or systems, it's really hard to not notice it. And I would just observe this sense of relief from patients after conversations with psychiatrists trained in this modality. And I just really wanted to be able to provide that to my patients. I think also my experience in supervision was also crucial. Really, anytime anything confusing, contradictory, or uncomfortable or otherwise would come up with a patient, there was something in psychodynamic theory that had a way of both understanding it and also kind of guiding me to the next step.
Yeah, so it seems like the psychodynamic aspect of psychiatry gave you a deeper sense of understanding as a patient psychiatrist. It also gave you a deeper understanding of yourself, and it gives patients a deeper understanding of themselves as well. Is that accurate?
Yeah, I'd say so.
Okay. And I understand psychoanalysis and psychodynamic therapy peaked in the 1950s and 1960s, but it became less popular afterwards. And I was just wondering what happened.
Yeah, that's a super complex question, but I think I think there are many factors that contributed to that. Though I will say, paradoxically, I think there is more support for psychoanalytic ideas today more than ever. One of the main reasons I think it fell in popularity is kind of a change in culture toward people wanting quick fixes to their problems. This is, of course, counter to the kind of slower, but I'd say more effective treatment with psychoanalysis, which actually in research has shown to provide long-term and actually increasing benefit well after the treatment has ended. So, of course, that's something that insurance wouldn't reimburse for. I think there was also, for some time, there was resistance to the establishment of a research evidence base supporting psychoanalytic treatments. And this ultimately led them to be excluded from treatment guidelines. So biological psychiatry and CBT then became known as more, quote, evidence-based, despite the fact that some factors make this appear more true than it is, such as outcome measures being skewed towards CBT. There's now significant research showing the efficacy and effectiveness of psychodynamic psychotherapy for many disorders and symptoms. And in fact, for characterologic issues, it may be the only treatment that works. So current studies are helping us better determine, which patients most benefit from psychodynamic psychotherapy versus a different psychotherapy or, a totally different intervention separate from psychotherapy. Some other factors include that psychoanalysis was one of the only treatments available. So with the advent of new treatments, of course, it wasn't the only option that we could offer to patients. Funding seems to go to biological treatments despite the positive effect of basic neuroscience on clinical care. And I think it's also important to mention that, unfortunately, there was a culture of psychoanalysts dismissing many different types of people and perspectives that, understandably and rightfully so, angered and alienated many people. It held now very outdated views about women, people of color, schizophrenia, homosexuality, and others. And it's now part of a history that has now been discredited within the field. There was also, an arrogance towards people with evidence, as I mentioned, and even towards psychologists at one point. So, fortunately, they've learned from their mistakes and, are actively now, inclusive and diverse in its theory and practice.
Wow, I didn't realize there was a history of discrimination among psychoanalysts, but I'm glad that this is over, especially since I feel like this form can be beneficial to so many different kinds of people.
Mm-hmm.
All right, moving forward, what is the role of psychoanalysis and psychodynamic psychiatry, especially as psychopharmacology and new treatment modalities like neuromodulations play a larger role in this field?
Yeah, what's interesting about the framing of the question is that it poses psychodynamic psychotherapy as in opposition to pharmacology or neuromodulation, when I really think psychodynamic principles are operating in every treatment we as psychiatrists provide. So, for example, every patient has a personality, and that affects how symptoms are explained and experienced and influences how they respond to ongoing treatment. So things like treatment adherence, treatment-resistant symptoms, and psychodynamic approaches to pharmacology, those are all topics that have been written about extensively. Transference, countertransference, resistance, they're all there influencing us and our patients, whether we, consciously acknowledge it or use it or not. Additionally, I think just as certain symptoms and diagnoses can only respond to ECT or a certain type of medication, there are some symptoms or difficulties that are likely only treated through psychodynamic psychotherapy. So I anticipate it's going to continue to be a valued part of a psychiatrist's toolbox.
Okay, that's good to know. And does it feel like maybe psychodynamic psychiatry is evident in a lot of different parts of psychiatry? It's just not thought about or discussed consciously, rather it occurs at a more subliminal level.
Yeah, I think so. I think it's, I think that we sometimes we as psychiatrists do it instinctively, but we don't really understand consciously what it is that we're doing. We just kind of know this person needs a more supportive intervention right now. Or if I say it this way, I think that they might experience it as criticism. So I'm actually going to say it this other way. When really, behind that is, likely something having to do with the person's past, unconscious way of relating to people. So, and unless it becomes an issue, you may never have to even address it. You can just kind of do that way instinctively. But in many situations, some of those interactions can become difficult or impede treatment. And that's when you really have to start examining the underlying psychodynamics of whatever is going on.
Okay, yeah, that's really useful information. And going back to more about the history of this form of therapy, who created the concept of psychoanalysis and when did it begin? I've heard of Freud and Jung, but were there any other influential figures?
Yeah, there were so many and are so many. So Sigmund Freud is considered like the founder of psychoanalysis, and he published his first psychoanalytic essay along with Joseph Breuer in 1895. And then since there have been many other psychoanalysts and psychoanalytic theories that have reshaped the field. So examples include Melanie Klein, Heinz Kohut in self-psychology, object relations theorists, including Otto Kernberg, interpersonal psychoanalysis, relational psychoanalysis, too many to recount. But I think this question helps me address a common myth that psychoanalysis today is the same as it was in 1895. Modern psychoanalysis is very different from how Freud was practicing then. That kind of caricature of the stiff, unemotional analyst who doesn't say anything during a session is nothing like a modern psychoanalyst.
Yeah, and I also heard that Freud, I was doing a little bit of reading myself, and I heard that Freud, in terms of human behavior and repressed emotions, was adamant that behaviors and emotions were driven by sex or sexuality. And his partner, Jung, believed that there was much more to it than this and that Freud was too negative. So Jung actually took over as the main influential figure in psychoanalysis and broadened its scope and led to, all these other influential figures that followed and eventually formed the psychoanalysis and psychodynamic psychiatry that we have today. So it was a very interesting read to see how things have evolved from the original Freud and Breuer, as you mentioned. So moving on to comparing psychodynamic psychiatry with other forms of therapy, I know CBT, or cognitive behavioral therapy, has become a hot treatment modality over the years. And I was wondering if you could talk about how it's different from psychodynamic therapy in clinical practice.
Yeah, so CBT and psychodynamic psychotherapy have different models of the mind, goals, techniques they use, and therapeutic frames. The conceptual basis of CBT is to understand the interaction of one's thoughts, feelings, and behaviors, and how this impacts the patient's symptoms. And the focus is really on problems in the here and now and identifying cognitive distortions and automatic thoughts, amongst other techniques, to improve your symptoms. The CBT frame is usually weekly, somewhere around 16 to 20 sessions, and it can involve homework assignments and things such as thought logs or exposures. And then again, as I was explaining before, psychodynamic psychotherapy uses a model of the mind that says that unconscious mental activity has an impact on our conscious thoughts, feelings, and behaviors. And it uses, again, those techniques like interpretation of resistances, defenses, using transference and countertransference. Those things are really unique to psychodynamic psychotherapy. But, both therapies do use supportive interventions that kind of overlap with each other. And then again, the goal, some goals for psychodynamic psychotherapy include improving relationships with others, your self-esteem, increasing adaptive functioning. And again, the sessions are typically 1 to 2 times a week, and treatment generally lasts longer than 20 sessions, but there are also manualized and brief psychodynamic psychotherapies that people frequently use.
I see. In my head, I see CBT, or cognitive behavioral therapy, as a means of putting out a fire caused by cognitive distortions, or the gasoline, affecting one's thoughts, emotions, and behaviors, whereas psychodynamic psychotherapy, on the other hand, works to understand why the fire might have started in the first place. Is this analogy accurate at all?
Yeah, I would say so. Yeah, and I would say that, I think it's sometimes a misperception, probably in both ends. That's like the taking both modalities in its most extreme view in order to kind of differentiate them. But I would say even within psychodynamic psychotherapy, supportive interventions, or kind of, putting out the fire, happens a lot. And you're kind of like moving between between putting out the fire, understanding where the fire is coming from. And I think also in CBT, you do have to understand kind of like what are your core beliefs that are behind those kinds of negative thoughts. So I think both have some flexibility within them.
Okay, that makes sense. You mentioned that, psychodynamic psychotherapy usually involves longer than 20 sessions. And my next question is, has the advent of managed care and insurance oversight on mental health treatment affected psychoanalytic psychodynamic psychiatry?
Yeah, I think the emphasis on shorter term treatments has emphasized kind of quick medication visits over psychotherapy appointments. And this is just another example of that kind of culture of the quick fix that I'd mentioned earlier. But insurance companies don't seem to want to pay for the treatment of personality disorders, despite the kind of enormous morbidity that accompanies them, and also strong evidence that they, complicate treatment of everything.
And this is probably a hard question to answer, but do you see this changing at all? Or is it one of those things where you have to see how society goes in terms of how people view mental health? Like if there's any movement away from the culture of a quick fix?
Yeah, I do. I think, number one is that more and more evidence mounts every day in terms of, the ability to treat personality disorders, and also effectively. So with that kind of research base, it's more of a leg to stand on in terms of getting insurance to cover that. And then also, if the quick fix doesn't work, then everybody looks to, okay, so this didn't work. What's my next option? What's my next step? So I think it'll, naturally kind of move in that direction. If people are motivated to make changes, they'll look to longer term options.
I see. That's good to know. And I was also hoping to talk to you about your specific training in psychodynamic therapy. Was it a strong emphasis in your program?
Yeah, it really was. Psychodynamic therapy in theory seemed to be present at every level and clinical setting for me during residency. From, again, the psychiatric emergency
Hmm.
room to the inpatient unit to my long-term psychotherapy patients, I felt like I was able to learn about it and use it.
That's great. And at my home institution, we just started learning about something called the Y model, where
Hmm.
the STEM contains common core dimensions of all psychotherapy systems like empathy, active listening, reflection, micro-counseling skills, and supportive therapy. And then there are two branches of that Y model representing CBT and psychodynamic psychotherapy. So I'm excited to, as you discussed earlier, learn their differences and similarities to use and practice. So what options do residents have during and after graduation if psychodynamic psychotherapy is not a particular strength at their residency program? I've heard of psychoanalytic institutes. Can you talk about the Columbia Institute of Psychoanalysis and your fellowship in particular as well?
Yeah. So residents or, really at any point in your training who are interested in further training in psychodynamics should absolutely reach out to their nearby psychoanalytic institute and introduce themselves. These institutes usually have programs for trainees and recent graduates to get a flavor of psychodynamic thinking without actually committing to full psychoanalytic training. But if you don't live near a psychoanalytic institute, there are sometimes virtual or online ways to connecting to them as well. So again, I really encourage you to, research that and reach out. Many institutes have monthly programs for residents still in training or public lectures where they discuss cases in theory. And then after graduating, additional training is often offered that can be done in tandem with your full-time job or private practice. Going to
Hmm.
the American Psychoanalytic Association meeting is also a really easy way to learn more. They have a fellowship that you can apply for, which pairs you with a mentor and gives you additional ways of exploring your interest. And then the Columbia Center for Psychoanalytic Research and Training also offers learning opportunities for all career stages: medical students, psychiatry residents, grad students, early career psychiatrists, scholars in other fields, or more senior psychiatrists as well who want to learn more. There are free seminars open monthly where an analyst presents sessions of a treatment and the group discusses how analysis works. Trainees can do electives within the program or attend monthly evening lectures that are more advanced. There's also a research group that welcomes trainees. They also have a psychoanalytic fellowship where you're assigned a mentor and can attend specialized seminars and get group mentorship with senior faculty members. For people who are committed to doing additional training, there's a 2-year adult psychodynamic psychotherapy program, again, consisting of weekly seminars and supervision. There's also a child and adolescent psychodynamic psychotherapy program, parent-infant psychotherapy program, transference-focused psychotherapy, and then just your full adult, adolescent, and child psychoanalytic training. My fellowship, the Aaron Stern MD PhD Research Fellowship in Psychodynamic Psychiatry, is through Weill Cornell Medicine, and that specifically involves learning how to teach and supervise residents and medical students psychodynamic psychotherapy with the goal of broadening its impact and accessibility to all clinicians.
So it sounds like contacting your local psychoanalytic institute is the way to go. And there are multiple different training options for different levels of trainees, from medical students to residents to people who have completed residency and are practicing. Is there a certificate of achievement for some of these programs at the institutes? And for the fellowship you mentioned, is it ACGME certified? I'm just wondering how one receives recognition for studying or learning at these institutes.
Yeah, I think it depends on the institute you're in. I know some institutes do have certificates, and others don't. Um, as far as I know, that it's not like an ACGME certified fellowship, but I would encourage you to contact whatever institute you're involved with and ask them those questions.
Definitely. The last question I had was, it starts during residency, but especially as a trainee in psychodynamic psychotherapy, being a patient yourself is very important, right? Because part of the therapy involves countertransference and understanding your own emotions. And also you want to see what it's like to be on the other side. So in your training so far, I was wondering, how has it helped you to be a patient during your psychoanalytic training?
Yeah, it's been incredibly helpful. So part of psychoanalytic training, there's a requirement for you to undergo your own personal analysis. But I was in therapy even before starting psychoanalytic training. And it's been so critical in developing my ability to understand, just like you were saying, my own blind spots and countertransference, or, any range of difficult feelings that can come up as a therapist. And I think kind of taking the time to explore that is really ultimately help benefit my patients.
Before we wrap up for today, are there any last words of advice you have for trainees?
Yeah. Reach out to your Psychoanalytic Institute. They're very friendly and welcoming and will be eager to have you. See what opportunities are there. Go to the American Psychoanalytic Association meeting, do their fellowship. It's out there if you look for it. And I hope everyone who's listening to this decides to take that step forward and explore it a bit.
Absolutely. I know I will. Well, thank you, Dr. Gorun, for taking the time to speak with us today. I found our conversation very insightful and informative, and I hope our listeners feel the same way. I hope you have a great day and take care.
Thank you. You too.